Hi, this is a podcast from the Physician-Patient Alliance for Health and Safety on ECRI'S 2016 Top 10 Patient Safety Concerns for Healthcare Organizations. We would like to thank both of our sponsors, Medtronic, our Platinum sponsor, and EarlySense, our Bronze sponsor, for their generous support of this clinical education series. Through the financial support of these sponsors, PPAHS can offer the education series with full independent control over all programmatic and editorial aspects of the series, including selection of the clinicians to be interviewed, discussion topics, and questions asked. I am Michael Wong, founder and executive director of PPAHS, and today with me from ECRI is Stephanie Eustace, patient safety analyst, and I also have with me Lynn Razzano, who is a clinical nurse consultant at PPAHS. Thank you so much for joining Lynn and I today to discuss ECRI's patient safety concerns, Stephanie.
Thank you for having me, Michael.
That's great to have you on. Now, ECRI recently released the top 10 patient safety concerns for healthcare organizations. How were the top 10 patient safety concerns selected by ECRI?
Well, Michael, we looked at various sources, ECRI Institute, the PSO component. We have, at the end of 2015, we had more than 1.2 million event reports submitted to the ECRI Institute PSO. So of course we had a good number of events in there. We also look at different things submitted to us from our PSO clients. They submit root cause analysis, so I mean it's easy to look at the topics to see which ones were submitted, what are some of the most common root causes that are submitted to us, and also we do something called research requests. So it's our member hospitals. They'll come in with questions to us related to different topics. So opioids, that's always one of the topics that we can that we do see quite often coming in. We also look at different newsletters that we put out, alerts from our healthcare risk control group. We look at those to see what goes out. So that's the information that we look at from our sources, from our members. But we also have, a vast, a lot of employees here with, a variety of, experiences. So we have professionals just in, clinical patient safety. We have health technology professionals and also investigation professionals. So we look for their input and also from our external ECRI Institute PSO Advisory Board.
Now, one of your top 10 concerns is inadequate monitoring for respiratory depression in patients receiving opioids, a topic which has, ever since the inception of PPAHS, has been one of our key initiatives. Now, inadequate monitoring was identified on your report as having a risk amount of 80, which is the highest rating among top ECRI concerns. How does the score, what does the score mean for clinicians and the patients, and how was it made up?
Well, let's start with how the score is arrived at. It's a multiplication of two different factors. Both of the scores are on a scale of 1 to 10. What we're going to look at is the patient harm, so what the potential of harm is to the patient, and then from there we also multiply that by the likelihood of this event occurring, and both of which are on a scale of 1 to 10. So the score is going to show that the events are 1, likely to occur, and 2, that they have the ability to cause harm. One of the reasons why, it's going to be likely to occur is opioids, they're frequently prescribed in the inpatient. Patients come in with anything from, pneumonia to broken hips. Post-op patients, they may be prescribed opioids. And, you may not know if what dose the patient will tolerate, when they come into the hospital. So if somebody's not going to tolerate, the dose of opioids that are prescribed, they're going to be at a, increased risk of harm.
Yes, there certainly is this problem of knowing exactly how much an opioid amount a specific patient can take. I know, Lynn, you could probably speak to that quite a bit, can't you?
Yes, and clearly, we need to consider, opioid naive patients, how we do our sort of, pre-surgical or pre-intervention, screening of the patients to determine if there will be at a higher risk for respiratory depression when receiving opioids.
In addition to the risk being opioid naive, but especially in the surgery patients, is the patients who have undiagnosed sleep apnea, and they're going to be at the increased risk for respiratory depression also.
Absolutely. That's a great point, Stephanie. So why does ECRI think clinical monitoring of patients receiving opioids will reduce the patient risk in terms of preventing harm related to the use of opioids?
I mean, that's a pretty short answer on that. Studies have shown and practice has shown that monitoring can lead to early recognition of respiratory depression, and with the early recognition of respiratory depression, it's reversible when recognized at an early stage. It's when patients have continued hypoxia that they're going to be running into problems. But if we catch them early, hopefully, we can reverse them.
So it's that continuous monitoring piece that is able to detect it, right, Stephanie, as opposed to, and obviously in favor of nurses. Nurses going around as much as they can to see patients, but the reality is they can't. So this continuous monitoring ensures that some kind of monitoring is being used on a patient at all times.
Well, the continuous monitoring is helpful, but sometimes the continuous monitoring isn't going to be available for all of the patients at a facility. I think continuous monitoring, it's been out in the literature lately, but it is still, I guess, more fairly new. Some places just don't have the resources, for continuous monitoring on all patients.
Are there patients then that you would recommend or have placed on monitoring if institutions can't monitor all the patients?
I know with the recommendations that are coming out from the facilities, it's going to be, post-operative patients, who are receiving IV opioids, also patients who are on PCA, patient-controlled analgesia. They're one of the higher candidates who will receive the continuous monitoring, especially if they're on a continuous PCA dose.
And that would include, the oncology patients hospitalized and receiving the treatment or coming in for a medical condition that requires intervention.
Yes, for the hospice patients. And also hospice patients, they may not be on PCA, but they can be on continuous opioid infusions, which is another high-risk population for respiratory depression.
Excellent point. More and more professional societies are issuing guidelines supporting the increased use of capnography for patient monitoring. In January 16, the Association of Perioperative Registered Nurses, AORN, released a moderate sedation guideline update saying the perioperative nurse should monitor exhaled CO2 and tidal CO2 by capnography in addition to SpO2 by pulse oximetry during moderate sedation analgesia procedures. This was also identified in January 2016 by the Association of Radiologic and Imaging Nurses, stating that it endorses the routine use of capnography for all patients who receive moderate sedation analgesia during procedures in the imaging environment. What is your perspective on this, particularly as it relates to ECRI'S concerns regarding respiratory depression related to opioids?
Well, for that topic, I'm going to refer to one of our other publications. ECRI Institute, we also put out the top 10 health technology hazards. And in the report that was just released from our health devices group, they also list, the failure to effectively monitor post-operative patients for opioid-induced respiratory depression as an issue. On their list, it's number 3 on their top 10. Throughout the section, we refer to the Anesthesia Patient Safety Foundation's recommendations. Okay. And we're looking at their essential monitoring strategies to detect clinically significant drug-induced respiratory depression in the postoperative period. Their recommendations are similar to the ones that you had listed. They're looking to consider continuous electronic monitoring, with O2-SAT for non-ambulatory patients receiving opioids, and also for acute postoperative pain while being cared for in the healthcare facility. So we're going along with their guidelines also, which mimic pretty much the two agencies that you just spoke of.
Should not using monitoring of patients receiving opioids be considered a medical error or perhaps a never event? Or put another way, should the use of continuous monitoring be a standard of care, Stephanie?
I guess as I referred to a little bit earlier, some facilities, it's going to be due to limited resources. All facilities, they may not have access to continued monitoring. This issue is recognized in the Anesthesia Patient Safety Foundation's recommendations, and they have, that the implementation of continuous monitoring, it may be a gradual process. So, it may be, like I said, the high-risk patients, facilities that are just starting to adopt it, stratify the risk of your patients and start with the patients who are most at risk for respiratory depression.
Yeah, so ideally everyone should be monitored, but the reality is that there are resource constraints that would require us to risk stratify and make sure the highest risk patients are monitored.
Just one comment, Stephanie. Do you think for those institutions that don't have the availability of continuous electronic monitoring for all their patients receiving opioids and they're high risk, do you think, a step-down unit or a higher level of acuity monitoring by, professional nurses is in order in that case?
I mean, again, you would have to look at the patient population, what, their risk factors are, and base it on there. Even if there is the monitoring available, the electronic monitoring such as capnography is available for those patients, they're still going to require the higher level of care. You still need that nurse, you still need that person in there who can evaluate the patient.
Excellent point. Stephanie, what are obstacles or barriers or challenges for the universal use of monitoring, particularly in high-risk patients for respiratory depression?
The main, I think, obstacle right now is resources and the, availability of the resources in the facilities.
Would electronic alerts built into the electronic health record for continuous monitoring when opioids are prescribed significantly decrease opioid-related harm?
I mean, if available, if the facility does have access to the continuous monitoring, that would assist, because you can put the notes in there for which patients should require it. Maybe it's going to be your post-op patients who are prescribed, the IV opioids, or the patients who are on the patient-controlled analgesia. It's the reminder for the physician to order the continuous monitoring, so that would assist. But if facilities don't have the continuous monitoring, but they do have the electronic record, Joint Commission, their safe use of opioids, they recommend alerts in the computer system just on dosing limits or, just alerts that the patient is on an opioid for, continuous monitoring, and not even necessarily for continuous monitoring, just for increased monitoring.
Yeah, that's an excellent point, too, what the Joint Commission recommendations are, in particular 2016 National Patient Safety Goals for alarm management protocols. Mm-hmm. In the ECRI brief, you say that opioid safety should be a nurse-driven protocol. Why do you believe it should be nurse-driven?
Like I said before, respiratory depression, it can be reversed, and recognized early. But if not, patients can sustain brain injury from apnea or hyperventilation. And what we've had reported to ECRI Institute PSO, all the events, there are event reports stating that, the patients were having adverse effects from opioids, and there were delays in reaching a physician, to prescribe the reversal agent.
That's an excellent point. So it would be a nurse-driven protocol / standing orders that a nurse could initiate.
Correct. And with the nurse-driven protocol, if I'm going to give, the reversal agent and be done, I'm going to give the reversal agent, I'm going to call the physician who will then come and evaluate the patient. Why did this happen? Should we lower the dose of the patient? Are they getting too much of the opioids? Because even if you call, a rapid response, it is a rapid response.
Right.
But by the time the team gets there, the reversal agent could be administered.
Exactly. Excellent point. In addition to the use of continuous monitoring, what tools do you think nurses should have to help ensure the safety of the patients receiving opioids? Do we need improved training or education for nurses, an improved sedation scale that's validated and user-friendly?
Facilities, they need to have a sedation scale in place, and not only have it in place, they need education of the nursing staff, how to use the scale. What does the scale mean? What am I looking for in the patient? Mm-hmm. But one thing to remember is increased educational programs and opportunities for nurses. Sure, that would assist with reducing the occurrence of respiratory depression, but it's not just the nurses who need an increase in training. Here in Pennsylvania, the Pennsylvania Patient Safety Authority, they conducted what they called it an opioid knowledge assessment test, and that was back 3 years ago in 2013. And we had close to, here in the state, almost 1,800 practitioners completing, the assessment, and that included nurses, physicians, pharmacists, nurse practitioners.
Respiratory therapists?
Yes, and I don't remember if respiratory therapists were on there. I would have to look again, but there were physician assistants and nurse practitioners on there also. On there, they recommended staff training on how to assess patients for adverse reactions, how to recognize advancing sedation. And it wasn't just a gap in the nurse's knowledge. It was, gaps in all of the healthcare professionals' knowledge of opioids.
That's excellent. And I definitely agree with that concept. It's not the nurse, that's the entire healthcare team. There's a healthcare team that surrounds the patient, care of the patient, all through this hospitalization and its continuum of care. Mm-hmm. So that's an excellent point.
Now, I think we've all heard in the news a lot of talk about opioid overdose, misuse, abuse, diversion, particularly the death of Prince and possible overdose that he might have had before his death. Now, the CDC says that there's an opioid epidemic and recently issued guidelines for prescribing opioids for chronic pain. What do you think prescribers can do to ensure their patients are receiving the opioids they need while at the same time helping to reduce misuse, abuse, and diversion?
I think one thing out there is awareness. The guidelines, they just came out last month, so some physicians, other healthcare practitioners, they're going to need to become more familiar with them. One of the main things through the report, it says you need to know the patients and their history. It's not just coming in for my visit this month and I'm going to write you a script. You need to, look at the guidelines. They have recommendations on, determining when to initiate or when to continue opioids for chronic pain. Also, review the patient's therapy, like I said, on a routine basis. Are they getting better? Is it helping them? Is the therapy working? And, are they experiencing any side effects from the therapy? And last, look at the risks and the benefit of the treatment and then decide whether or not to continue the patient's therapy. Talk to the patient. Talk to your patients about the possible side effects. A lot of times they think, I'm going to take a pill and I'm going to get better. And, hopefully that works, but, there are risks with taking that pill, and, you want to make sure that it's best for the patient. I think one of the other recommendations that come from the guidelines, it comes with the acute pain use. For the initiation of acute pain, the guidelines specifically state to give the lowest effective dose and the immediate release formulation, and a limited to supply. It's 3 days. More than 7 days is rarely going to be needed. I mean, I've been practicing for over 20 years as a pharmacist, and it's not unusual to see patients come in, post-op or even, post-dental procedure for 30 or 60 doses of an opioid. That therapy can be 7 to 10 days. So do they really need that? I mean, I had surgery, this was about 10 years ago. Didn't require any pain med post-op. Discharged the next day, I was offered a prescription for 30 tablets of an opioid. It's like, I don't need it. I don't want it. But I think a lot of times the first thing for, acute pain is I'm going to write you an opioid and it's going to make you better.
Right.
Sure. No, you're absolutely right. You could have had no opioid days for as a prescription, or you more appropriately should have had 7 days, and as opposed to having another 30 days or so of supply in your cabinet, which could have ultimately reach someone that shouldn't have reached. So,
right.
Great point with that.
And then with, like you had said about the cabinet reaching it where it shouldn't, other people will have access to it then, and that's one of the important things when you see the commercials and the public service announcements. You need to tell your patients how to dispose of them. Don't just leave them in the cabinet. The DEA take-back days, or, a lot of police stations now have drop-off bins. Get them out of the house.
But that decision should have been made, as you say, Stephanie, at the beginning when you were prescribed the opioids. How much did you really need? Whether did you really need it?
Right.
Was it appropriate? And then how much do you really need to manage your pain?
And I think, Stephanie, recalling what you mentioned about, that we should take a good retrospective history of what has worked for that patient, particular patient, in his pain control in the past. Does ice work for him? Does heat work for him? Does relaxation techniques or, listening to music via headsets, work for him, and embody that sort of in the care plan of the patient, even facing surgery?
Right. And even non-opioid pain relievers.
Right.
Would that be sufficient?
So, Stephanie, thank you so much for this great discussion. I know Lynn and I really, really appreciate your thoughts on patient safety and what prescribers, doctors, nurses, and others that are working in this area can do to help their patients and improve safety. Thank you so much.
Thank you.
Thank you, Stephanie.
We would like to thank both of our sponsors, Medtronic, our platinum sponsor, and EarlySense, our bronze sponsor, for their generous support of this clinical education series. Through the financial support of these sponsors, PPAHS can offer the education series with full independent control over all programmatic and editorial aspects of the series, including selection of the clinicians to be interviewed, discussion topics, and questions asked. Medtronic is a global leader in medical technology, services, and solutions. Medtronic improves the health and lives of millions of people each year. Medtronic believes its deep clinical, therapeutic, and economic expertise can help address the complex challenges such as rising costs, aging populations, and the burden of chronic disease faced by families and healthcare systems today. But Medtronic can't do it alone. That's why Medtronic is committed to partnering in new ways and developing powerful solutions that deliver better patient outcomes. EarlySense delivers continuous monitoring solutions designed to enhance proactive patient care for non-ICU general care patients. The EarlySense system provides continuous and contact-free monitoring of heart rate, respiratory rate, and motion for early detection of patient deterioration, fall prevention, and pressure ulcers prevention.